This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from Epilepsia Open, published in 2026, titled Scalp Fast Oscillations Detected by High-Density EEG as a Non-Invasive Predictor of Surgical Outcome in Temporal Lobe Epilepsy with Hippocampal Sclerosis.
This is a topic that hits home for many of us in the OR. When we talk about drug-resistant temporal lobe epilepsy, or TLE, specifically with hippocampal sclerosis, TLE-HS, we are looking at one of the most common indications for epilepsy surgery. We perform an anterior temporal lobectomy, or ATL, with the goal of seizure freedom. But as any resident or attending knows, the outcome isn't always a guarantee.
Exactly, Dr. Aris. The challenge has always been finding reliable, non-invasive ways to predict which of these patients will actually achieve that angle+1 outcome. This study evaluates a specific biomarker, scalp oscillatory patterns, specifically what they call scalp fast oscillations, or SFOs.
Now, for the residents listening, when we talk about fast oscillations in this context, we are looking at frequencies above 30 Hz. Historically, we've relied heavily on intracranial EEG to capture these high-frequency signatures because the skull acts like a low-pass filter, dampening those signals. But this paper explores a different route.
Right. They utilized 256-channel high-density EEG, or HD-EEG. By using such a high spatial resolution, 256 channels, compared to the standard 19 or 21 we see in a routine clinical setup, the researchers wanted to see if these SFOs could be detected on the scalp, and more importantly, if they are associated with surgical outcomes after an ATL.
It's an ambitious objective. The study essentially asks, can we use HD-EEG as a non-invasive predictor? Ilara, let's dive into the patient population they focused on.
The study specifically narrowed its scope to patients with drug-resistant TLE-HS. These are patients who have failed medical management and have the classic imaging and clinical markers of hippocampal sclerosis. They all underwent an anterior temporal lobectomy. The key here was evaluating whether the presence or localization of these scalp fast oscillations, detected preoperatively, correlated with how they did postoperatively.
It's important to emphasize the non-invasive aspect for our medical students. In the past, to get this kind of high-frequency data, we might have had to place depth electrodes or subdural grids. If we can achieve predictive accuracy using 256-channel HD-EEG, we are significantly reducing the risk and burden on the patient during the workup.
And the fast oscillations over 30 Hz are the star of the show here. The abstract notes that they were specifically looking at how these SFOs are associated with and can predict surgical outcomes. If the SFOs are coming from the area we are planning to resect, the temporal lobe, and that resection leads to seizure freedom, it confirms that the SFO is a valid marker of the epileptogenic zone.
From a surgical perspective, this is about refining our patient selection and setting expectations. If a patient's HD-EEG shows SFOs that are widespread or outside the standard ATL resection zone, we might be more cautious about promising a complete cure. Conversely, if the SFOs are well localized to the sclerotic hippocampus and surrounding temporal cortex, our confidence in the ATL increases.
The study really pushes the boundaries of what we thought was possible with scalp recordings. By identifying these oscillatory patterns non-invasively, we're bridging the gap between the standard scalp EEG and the more invasive intracranial recordings.
It's a leap forward in precision. For the practicing neurosurgeons out there, think about how this might change your multidisciplinary epilepsy board meetings. Instead of just saying, the MRI shows hippocampus sclerosis, we might soon be saying, the 256-channel HD-EEG shows localized scalp fast oscillations over 30 Hz, which gives us a high statistical probability of a favorable surgical outcome.
It adds a whole new layer of physiological data to our anatomical findings. The study highlights that these SFOs are not just noise, they are non-invasive predictors.
This is definitely a space to watch as HD-EEG technology becomes more accessible in clinical centers. If we can predict surgical outcomes more accurately using a 256-channel cap rather than a surgical procedure for electrode placement, the field of functional neurosurgery takes a massive step forward.
Definitely. It's about getting the right patient to the OR at the right time with the best possible data.
Well, that's all the time we have for this episode. A quick but deep look into the future of epilepsy workups.
Thank you for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.
Stay sharp.